Welcome to PSI's webinar, Non-Suicidal Self-Injury Prevention and Intervention Strategies for School Staff. Hi, I'm Karen McKelvey, PSI's Director of Professional Development, and on behalf of all of us at PSI, we're pleased to be hosting Meredith Sitko and Richard Lieberman. As part of PSI's ongoing professional development efforts, our goals are to provide training that prepares our staff with the latest in information on current topics that affect job roles. As health staff, this information is vital in your service to our partner schools and our students. I'd like to turn the program over right now to Meredith Sitko.
Thank you, Karen, and thank all of you very much for logging on today. We appreciate all of your hard work and dedication to the students you serve. And as Karen was mentioning, we really feel today's topic is very pertinent to our role in the school setting, and we are pleased to be able to offer one CEU approved by the Ohio Board of Nursing for today's program. The CEU certificates will be emailed to your psihealth.org email. Thanks again for taking the time to attend today's presentation. We hope to provide you with useful tools and resources to utilize in your role as a nurse in the school setting.
Thanks, Meredith. Our expert partner, Richard Lieberman, is a nationally certified school psychologist and currently serves as lead consultant for the California Student Mental Health Initiative for the Los Angeles County Office of Education. He is a lecturer in the Graduate School of Education at Loyola Marymount University, and from 1986 to 2011, he coordinated suicide prevention services for Los Angeles Unified School District. Mr. Lieberman is co-author of School Crisis Prevention, the PREPARE Model, and Best Practices in Suicide Intervention for the National Association of School Psychologists. Rich has written numerous books and chapters and articles on youth suicide prevention, crisis intervention, and responding to self-injurious students in the schools, and appeared in many videos, including the HBO documentary Suicide. Mr. Lieberman serves on the steering committee for the National Suicide Prevention Resource Center and 2 task forces of the National Action Alliance for Suicide Education and Prevention. Before I turn the program over to our presenters, I want to say that we will be recording this session and it will be archived and stored on the PSI website for further usage by our registrants. If time allows, you can submit questions that will be answered at the end. You utilize the control panel on the side of your screen, much like an instant message. Upon completion of the webinar and submission of an evaluation, you will receive a certificate of completion via email within a week to 10 days. We will also post the PowerPoint plus some additional handouts provided by Rich along with this recording on the website. And now I'm very pleased to present Richard Lieberman.
Thank you, and good afternoon, everybody. I want to thank Karen and Meredith. Thank you for that wonderful introduction, just like my mom wrote it. That was great. I really appreciate the opportunity to present today. There's something I have in common with everyone listening today, and that is the desire to beat the Celtics. So I know that you got a game to go to. I see the first note in the box is, why don't we go straight to questions? Because I know everybody's got to get to that game in time. It's a pleasure also to present to school nurses and nurse assistants. Here in Los Angeles Unified School District, the foundation of our suicide prevention program was a mandate that every school have a school crisis team. And it was also mandated that our school nurses were a critical part of that crisis team. I think they're essential, is particularly in responding to suicidal students and self-injurious students, when suicidal students return from hospitalization, when students are on meds for a variety, spectrum of mental illness, including depression, school nurses and nurse assistants are extremely essential gatekeepers of youth. And besides, you're also a fun group to present to. The only disadvantage today is I can't interact with any of the participants. We're not going with video either, so if any of you are wondering, I do look a lot like LeBron. I've written about this complex behavior for many years, and within the last decade, we've seen the term change from self-mutilation, self-harm, self-injury, and now non-suicidal self-injury, built right into the title that these students are not cutting in a suicide attempt. So you can see a definition. It's a variety of behaviors in which an individual intentionally inflicts harm to his or her body for purposes not socially recognized or sanctioned. And this is a question I often get. This refers to behaviors like tattooing and piercing, which we won't be talking about today, as those are socially sanctioned. But without suicidal intent. When students want to die, they want to be out of pain. When kids cut, they want to feel better. Let's take a look at some of those behaviors. And when we look at these behaviors, let's look through a developmental lens. By the time kids get into high school, 3 out of 4 kids who engage in non-suicidal self-injury will use either cutting or burning. In elementary school age kids, we see a more equal, I guess, populations between boys and girls, gender issues. But we also see a wider variety of behaviors. So we'll see behaviors like kicking, poking, scratching, hair pulling, nail biting. A kindergarten, a 4th grade nurse, and she said, I have 20 4th grade girls in my office, all with a mysterious burn on the back of their arm, and they're all sworn to secrecy. Send everyone you have. This is an example of a rite of togetherness. Those are 20 kids all bonding together through a common act of self-injury. But at the elementary schools, I would ask you, what method do you think they used to create the burn, and the not having access to lighters or cigarettes that older kids would have? They used erasers. So it is a nurse's worst nightmare during these group events because kids tend to share implements. So they all shared the same eraser. It was very complicated. But I love the sworn to secrecy part. The first thing I said to them is, divide those students up and they will sing. And that's exactly what they did. And there's very important parts of the evaluation, which I'll cover later, in terms of assessing these group expressions of self-injury. You also see the choking game listed there. This is where I would also ask, and maybe go into this topic a little more, maybe we can save it for the end. Choking game being a very dangerous game that younger kids play, in which they restrict the flow of blood to the brain through restricting or cutting off the blood flow at the carotid artery. Many times it is played in pairs where one student will hyperventilate and another student will grab that person from behind very quickly, which when you lose oxygen flow to the brain, what happens? Obviously the student begins to lose consciousness. It is very dangerous when this game is played by a person alone. So it's something that we need to raise awareness amongst parents and those at school. One of the things we look for are bruises around the neck, so we have to re-look at the hickey. now to see that it isn't quite a black and blue mark. Anyway, very dangerous and has resulted in accidental deaths. When we also see jumping from high places, which is an elementary theme for kids. One of the things that I do want to caution all of you that work in elementary schools, it'd be really good if you could advise the principal to ban the pencil sharpener, that little plastic pencil sharpener. Because at elementary school, those plastic sharpeners, once you kind of break them, I ran a hotline to the schools, and I remember the day that the first call came in saying the 5th grade boys found that 3/4-inch razor that appears in all those pencil sharpeners. So I've been a real advocate. We don't need them. We've got other ways to sharpen pencils at school, to just do away with that if you find these kids have discovered that pencil sharpener. We're going to talk about some classifications of non-suicidal self-injury. There's a big discussion in the literature about compulsive versus impulsive expressions. You can see compulsive forms of self-injury, things like eating disorders, trichotillomania, which is the hair-pulling disorder. There's a strong association between eating disorders and self-injury. About 1 in 3 of those with eating disorders engage in non-suicidal self-injury. Very similar in terms of disorders. They have onset in early adolescence. We tend to think it's primarily females. There is an issues of control in eating disorders, the binging and purging, binging giving up control, the purging getting control back. It's a very complex disorder, very difficult to treat. Very often it requires both therapy and medications. But today we're going to focus on episodic self-injury. Those that kids do on an episodic basis to seek a temporary respite from distressing thoughts. There are 2 kinds of impulsive expressions of self-injury, those that are done episodically and those that are done repetitively. Now, when we take a look at a repetitive cutter, how might we detect a repetitive cutter? And that is someone who might have fresh scars mixed with old scars. In the old days, we would tend to think right away that 100% of the time this was a very serious borderline personality disorder. But when I took a look at the research today, we found somewhere, close to 60% of those with that repetitively self-injure, 50 to 60% will have a high incidence of adverse childhood experiences or trauma in their background. We can take a look at some of the facts. Most often beginning in middle adolescence between ages 12 and 15, probably as many as 70% of adults who engage in self-injurious behavior, they started as teens. It's generally assumed females engage in these kinds of behaviors, but there are a lot of studies now showing equal incidence between the genders, but it runs across all ethnicities, thought to be generally Caucasian, white behavior, but it has been found across all ethnicities and at all ages. We see that about 6 to 8%, well, up to 24% of youth have self-injured, and 1 out of 4 of those will report only doing it once. So we have a large population that is just experimenting with the behavior. However, about 6 to 8% will report repetitive non-suicidal self-injury with a high incidence of trauma in the background. You see a handout at the back, Cornell program, What is Self-Injury? So we've sent along a handout to be included when you revisit the website to find the slides for today's presentation. I believe that I have a responsibility only to steal from the very best, and I want to give lots of props to Cornell for their non-suicidal self-injury program, their website, and their resources. So you could go to that resource on your own and find handouts for parents, handouts for staff, and a few others that we'll talk about today. You can see in the quote, in one study, 92% of school counselors reported working with a student engaging in NSSI. I tell my school psychology and school counselor students at Loyola Marymount University that it's actually higher. There is a 100% chance that you're going to work with a suicidal student or a student engaging in self-injurious behaviors. So it is critical for all staff to learn about it and to learn about what to do. Let's take a look at some factors that contribute to non-suicidal self-injury. Self-injury is the result of a very complex, opportune, and clever interaction between as many as 6 factors. And you can see cognitive, affective, behavioral, environmental, biological, and psychological. Here's a diagram. You can see in the center is the adolescent, and thoughts, cognitive thoughts will lead to emotional distress, which will result in behaviors to relieve that distress, and that's how self-injurious behaviors once a student is exposed to it. You can see that it is impacted by nature-nurture, so there are biological factors and environmental factors as well, and oftentimes these can collide in an adolescent and result in psychological problems as well. Psychological problems will also have impact on how a person thinks and feels and how they behave as well. So what I'm going to do is go through all of these factors, talk a little bit about these factors, and then kind of give you suggestions in working with these kids for all of these factors by the time we finish up today. So let's take a look at cognitive. You can see now what teenager doesn't have at times irrational thoughts, beliefs, and assumptions. So these thoughts, the thoughts that have been tied the most in the literature around precipitating self-injurious behaviors are thoughts of self-derogation, self-blame, and self-punishment. Many times these students feel a tremendous amount of shame and blame for trauma that has come upon them, particularly children who have been abused or neglected or sexually molested. So these thoughts can cause emotions to move quickly between many different kinds of emotions for kids. They can go from feeling anger and fear to guilt and shame and grief, or they can feel them all at the same time and respond as we do when exposed to trauma, which is through numbness, and sometimes the non-suicidal behavior is designed to kind of break that numbness for them. One of the things we see in almost all of the psychological disorders involving self-injury is we see this emotional dysregulation, kids having a very difficult time regulating and controlling their emotions. Now we expose the adolescent to nature nurture, the environment that surrounds the student. I mean, to begin with, you can see at the fourth point there is that the vast majority of kids, especially the younger children, are going to be exposed to self-injurious behaviors through their peers, through their siblings, their older brothers and sisters, oftentimes through the media, through the internet. I know that many of you have worked in schools that have emos, but short for emotionals. Emos here are kind of, and you have worked with goths. So emos are kind of goth lights, dark view, black hair, black nail polish, black lipstick, and the thing for emos is that they have a tremendous need to connect with other kids, and the internet provides that anonymous way to interact with others while you're still alone in your bedroom. We see invalidating environments. There have been some studies that have shown that kids that engage in these behaviors have emotionally remote parents. Particularly, I would say this would apply to LGBT students. Extreme factor in raising risk in LGBT students is are invalidating environments, are homes where parents reject them for their feelings. We've talked also, the environment can provide adverse childhood experiences through a traumatic event. Of course, to be sexually abused once, to be traumatized, but to be abused over time, over years, is a very complex form of trauma. We also see that environments provide stressors on a daily basis, for kids. What are some of the crises, situational crises that have been associated the most with this kind of behavior? We've talked about victimization and exposure to violence, but perhaps the most common factor, and certainly the most common factor in youth that have attempted suicide here in Los Angeles, or died by suicide here in Los Angeles, is a precipitating event, a recently suffered loss of some kind. You do see a number of losses that kids cope with, but perhaps the most overwhelming loss, one would think that exposure to a death of a loved one, exposure to the death of a loved one by suicide would be the most impactful loss for teens, but some of the research says that even greater than that is the loss of romance, the boyfriend-girlfriend breakup. And also, when we see a loss of dignity, when kids are bullied, once again, particularly LGBT kids who are bullied, this plays it's how we associate these kinds of behaviors with suicidal ideation, suicidal thought, raising risk in kids, school crises, a disciplinary crisis, an academic crisis, or family crises precipitate episodes of self-injurious behavior, particularly in that last group, an argument with parent, and of course being exposed to domestic violence. Now, it is key that we, in developing treatment plans for kids, that we find out exactly what kinds of crises bring on this emotional dysregulation and feelings of tension and pressure and the need to self-injure. It's very important so that we can begin to incorporate into the treatment plan a plan for how to respond to these kinds of crises. Of course, the biological, and this is where we really depend upon nurses and assistants for their guidance on crisis teams. The biological factor that's involved here is a very strong reinforcer, and it's tied to the opioid system that controls pain, reward, and addictive behavior in the brain. As a kid cuts, the brain secretes powerful endorphins, such that if you were to ask a girl that is suffering from repetitive cutting, doesn't that hurt? You might get an answer along the line of, no, I feel a sense of relief or release. And that is the effect, the powerful effect of the opioid system that just dumps antidepressant endorphins into the bloodstream to create that sense of relief. The problem with this is when the behavior becomes addictive and becomes repeated, the opioid system eventually wears down. And as with any other substance or drugs, it will eventually give the message, I need a stronger push. So sometimes the message is you need to cut more, you need to cut deeper in order to get the same internal push. And when the environment and the biological vulnerability come together, we do see psychological disorders. These are the disorders most associated with non-suicidal self-injury. And once again, you can take a look, a borderline personality disorder, that would be, impossible to put a diagnosis of borderline personality disorder on an early adolescent teen. However, some of you that work, some of you in the mental health field, some of you in the nursing field, have worked with some 14-year-old girls that do look very much like a potential borderline personality disorder is developing. So these are very serious. You can see depression. Now, there are numerous kinds of depression. There are depressions that known as major depression that is profound and of short duration. Then there is a depression that is of lesser intensity but lasts for a longer period of time, otherwise known as dysthymia, and bipolar depression. And the bipolar disorder is the disorder most associated with these kinds of behaviors and suicidal thoughts and suicide attempts. And we've already talked about eating disorders. So what do kids report? These are some comments that I've collected from students over the years. As you can see, there are many, many different functions to this behavior. Some want to feel a concrete pain when psych pain is overwhelming. Schneidman, one of the early suicidologists in America, referred to this as psych ache. And I've always liked that term to describe that aching pain that sometimes a student can feel is overwhelming. Once again, reduces numbness. Sometimes kids have said things like, I just want to feel something. Interesting on this list is gets the attention of others, because parents sometimes their first line of, oh, she's just doing this to get attention. Well, of course, my answer to that is, yeah. And if we don't respond, wait till you see what they come up with next time. But for cutting, in general, the student is not asking for attention towards themselves, which is why they do it in isolation, which is why they take great pains, if you will, to cover it up or conceal these kinds of wounds. But we did see in the literature that sometimes this behavior is designed to get the attention of a specific other. And a specific other, at times, I would refer to as an alpha perhaps in the group, and we'll talk about that in another second or so. As you can see, I do this to punish myself. Once again, it is very important to determine what the function is for the individual student so that we can draw up a very relevant treatment plan. These are some things that we've just kind of talked about. If the behavior is increasing, if a kid is repeating this behavior, basic behavior theory would tell us there's a reinforcer somewhere. So once again, it's important to figure out what these functions are so that we can come up with a really good treatment plan. But as you see, there's positive reinforcement and negative reinforcement, internal and external. Interestingly, the two that come out the most in the literature is the positive reinforcement internal, the opioid system that creates a desirable state, and the external or the social contingency of getting the attention from others in particular. Some of the general signs of non-suicidal self-injury, and this is one of the reasons to hand out a good handout to staff at your school to look for these kinds of signs. Nurses are in a very unique position to discover non-suicidal self-injury. Kids tend to pick the insides of the arms, the insides of the thighs, and across the abdomen, because these are areas that they can be easily concealed. My coaches at school, at my high school, at once reported to me that, you know, during the cheerleading season, where it's a bare midriff season. Of course, it's not bare midriff weather in Cleveland today, that's for sure. But sometimes, in order to get around that, some students have been discovered to self-injure within the lining of sports bras. So some of these students will refuse to swim or dress out in PE or want to come in to use the nurse's bathroom for privacy because of these. They will really make an effort to appear perfectly normal and uninjured. We see sometimes the possession of a sharp implement. Generally, there is a favorite implement that is kept in a very private place, either at home, in the locker, in the purse, on their person somewhere. That is their favorite implement. And sometimes these have to be searched for when a student is hospitalized here in Los Angeles. On 72-hour holds, some kids can be very sophisticated to sneak these implements in many different kinds of ways. Let's just talking to kids about non-suicidal self-injury. I really like the phrase "a respectful curiosity." Once again, I stole this from Cornell. And you can see the handout down below, which is a handout that will help provide some insight as to how to kind of approach kids about non-suicidal self-injury. We always want to connect with caring and calmness and compassion. That actually comes from this understanding that, you know, the adult understands that this is the student's way of coping. Maladaptive as it is, harmful as it is, and sometimes it can be really tough to see these kinds of wounds. But believe me, if the student knew of ways and felt confident of other ways to cope with certain situations, they would not feel the need to harm themselves. Professionals need to take a respectful curiosity. Refer and go with the student to the school counselor. Now, keep in mind that if you discover a student has an open wound, Everyone in the school is a mandated reporter, and harm to self, harm to others, along with the reporting of the suspicion of child abuse, neglect, or endangerment are all mandated actions of any employee in the school. So you want to follow all your local policies on how to proceed. Here are some helpful questions. Included just a couple of slides with some helpful questions in terms of approaching the topic. Remember, one of the most important things would be to be asking these questions individually with students when you have them one-on-one in terms of exploring it. Here are some questions that would help to determine, what is really stressing the student out. Some helpful questions that parents could ask as well. But the most important thing in terms of tips for educators, I think one of the most harmful kinds of comments one could make to a student would be those kinds of comments in front of others. So this is a definitely don't list right there. Don't never publicly humiliate the student. Talk about their self-injury in front of the other class. Don't act shocked, overreact, say or do things to cause guilt or shame. Sometimes parents do this. I think the most difficult thing is when a student hears something from an adult who is trying to be caring by saying, "Oh, that's disgusting, just stop doing that." I think that it is just stop doing that when you can be a harmful comment, because if it is their last coping ability, when it is taken away from them, that indeed is when kids will think about suicide, thinking about hurting themselves in a more dramatic way. And parents can do this a number of ways. If you do that again, you're grounded for life. If you do that again, I will put you in the hospital. If you do that again, you will never see those kids again. So those all can be very harmful statements to kids. And when they hear it from someone at school, I'm sure they're thinking, you have no idea what I'm going through. Going on to some interventions. Schools must provide interventions that not only address the student's individual needs, but the impact of their behavior on peers as well. So a number of these suggestions are geared to this right of togetherness, which one of the things that really distinguishes non-suicidal self-injury in adolescents from adult populations is the issue of contagion. Same thing with suicide. These are contagious behaviors that can run through schools. They can be run through a classroom, a grade level, a building, a team. But one form of this, and this is the time of year where I most experience this, when kids, particularly 5th and 8th graders that are facing going on to middle and high school, these kids search at this time of the year for kind of a group reassurance, a group bonding through a symbolic act of self-injury. That's when I'll get a call. I have 7 7th grade girls in my office. They're all talking about suicide. They all have a mysterious cut on the back of their arm. Send everybody you have. These kinds of rites of togetherness are kids struggling to bond with others. When you have numbers like 7 or 20 4th graders, it's not one peer group, but representatives of different peer groups all trying to come together. Sometimes you will find in the middle of this an alpha student That's kind of setting off the whole crew. Sometimes alpha students, if they're boys, if the method is cutting, will say to a boy that wants to be part of the group but doesn't want to cut himself, that's okay, you can be part of the group, I will cut you. So these are very complex social rights, if you will, and the impulse for administrators is going to be to put all these kids in the same classroom. And I'm here to tell you, don't do that. Write that down. Don't do that. What we want to do is divide these kids up and talk to each one individually. And certainly what we want to find are individuals that are at risk. Sometimes they may share, nobody knows this, but I attempted suicide last year. Don't tell anyone, which would be important to know. But what would be also important to know is to identify that alpha student, because that alpha student could be someone in need of immediate referral. I know that Scott Poland is coming to do another webinar next week for schools on school response, so I'm going to leave this slide and hope that you tune in to my partner Scott. He will be absolutely riveting. However, not as riveting as I, but he is very knowledgeable about this topic and helping schools respond to it. Let's do some treatments and some suggestions, and then we'll open this up for some questions. Whenever you're dealing with thoughts and feelings and behaviors, the evidence-based treatment that you're going to find most in the literature is cognitive behavioral therapy. So I think to talk just very little bit about this is you can see that to a cognitive behavioral therapist, everything stems with the thoughts. If you can change how we feel, if you can change how we think, then we can change how we feel and we can change our behaviors. I think the most potent part of cognitive behavioral therapy is teaching kids that they have some control over some of these overwhelming thoughts and emotions that come up for them. So let's look at some cognitive recommendations in working with kids. I think it's very important for the mental health professionals working with these kids on a long-term basis to have established goals and have homework. I think that's really important. But for the role of the nurse that is talking with the kid at the end of the school day, and the student is sharing some of their innermost thoughts, helping students to reframe those thoughts in the way of just let's look at this a little bit differently as to how you can respond. I think one of the things that could be most helpful in this group is journaling. And I have seen kids really respond to this. We're going to talk about a particular kind of journal in a little bit, known as a trigger log, which is combining journaling with a log on self-injury to help us determine, the frequency and what kinds of events would lead to it. But for the younger children, very powerful in working with them is drawing and collage work. So as students maybe are waiting in your office, always having crayons for the younger ones so that they can draw. Many times those drawings can be a wonderful avenue for kids. Now, as we go through these 6 factors, in general, we're going to focus on 3 kinds of suggestions. Tension release, distractions, and substitute behaviors. So when we start talking about emotional regulation and things like relaxation and diaphragmatic breathing and imagery, using imagery, all of these techniques are designed to distract from distressful thoughts. So you can see sometimes if a student comes in agitated, if you can have them close their eyes, try to concentrate on the here and now. You will hear some in the future about an up-and-coming intervention known as mindfulness. And being in the here and now is a significant component of mindfulness. So having a student sit down, close their eyes, name 5 things that you see or hear, and have kids concentrate on the here and now as opposed to what happened a couple of hours beforehand. The very powerful thing about knowing the relationship between thoughts, feelings, and behaviors is that you really don't have to start with the thoughts. You can start with behaviors. For example, the most powerful tension release, and what I think kids should be doing more, certainly at school, maybe when it gets a little warmer or through indoor tracks, is have walking groups. I would not have walking groups for cutters, but I would have walking groups for kids. I think everybody knows the value of exercise. I think when you combine it with goals and homework, things like, all right, we're going to walk 3 times this week at school. A kid walks for 1 week, they feel good about themselves. But if they walk 3 times a week for 3 weeks, they will actually know what it's like to feel in shape. And the best part about starting with exercise, not only will they feel better about themselves, but 2 other symptoms of depression get better on their own. And that is the child sleeps better and eats better. And that's all we want. So as far as exercise, tension release, my recommendation would be let's start some walking groups that meet before school, during lunch, after school, so that kids, and that's also perfect time for adults at school to be connecting with kids in an informal manner. I think when the bell rings and kids move to classes, staff move to faculty lounges, and I think that we need to change that. I was out there standing supervision for many, many years. I know it certainly wasn't one of my favorite activities, but you know what? After a while, those kids began to depend upon the fact that I was going to be in a certain place at a certain time. So I think that that's very important, adults connecting with kids. Now, of course, these are replacement behaviors. These are some behaviors that kids have told me about. These are all suggestions that came from kids. You'll notice that a lot of these have to do with sensory input. So hot candies, aromatherapy, scribbling with a red crayon. Sometimes kids have said, I need to see red. So what some therapists have done at times is try to substitute a red magic marker for a sharp implement. As the behavior becomes more addictive, one might have to use more negative replacement behaviors. My suggestion for these would be to get parent permission, because the goal here is to move kids off dangerous implements like razors and burning, and to move them to some other replacement that might get the same endorphin push. A common one is a rubber band, and when kids feel the urge to hurt themselves, they snap the rubber band, which actually causes the brain to do the same endorphin push. Sometimes substituting ice or the magic marker for a sharp implement would be recommended. Holding books out at arm's length, standing on tiptoes. The most important thing here is get parent permission. This is that trigger log that we were talking about. And the trigger log is a self-assessment sheet, and we get kids logging their week, and every day they write whether they self-injured or whether they didn't. If it was a day that they self-injured, what happened. And of course, we want to find out a little bit. Let's measure this on a scale of 1 to 5. Just how upset were you? How well do you think you handled yourself? What were the consequences, and would you do anything different? For those of you that are assistants to nurses out there, some of these suggestions would be beyond your exposure. The one thing that I do want to suggest is that, and I'm sure you get a strong message about that, anytime you are concerned about a student, seek supervision. You have supervisors not only at PSI, wonderful supervisors I might add, but you also have supervisors out in the field, in school, and in the district that you're working. So always seek. Here is one of the most important pieces of advice I give to all crisis team members. Collaboration is your liability insurance. So whenever you are working with a student who is at risk and at risk of harming themselves, you always want to collaborate and seek out that supervision. I always look to the nurse when medications are involved, and very clearly we have many kids on meds. Some parents do not want at the school to know they are on meds. Perhaps the most dangerous thing for kids who are on medication for depression would be going on and off drugs, which can raise risk exponentially than either not being on the drug at all. So it is very important when kids return from hospitalization that the nurse can seek the parents out, get releases of information forms signed, consider which teachers may need to know that students have started medication so that any change in behavior needs to be noted. I would feel comfortable if all the kids that were on meds got there through a child psychiatrist, but here in Los Angeles, and probably by you, the #1 prescriber is the family physician. So very often they are not as sophisticated in adapting adult medication to children. Anyway, I do believe that monitoring the meds for up to the first month or two is absolutely critical to look for any changes in behavior. And just to mention at the end, perhaps the #1 effective evidence-based therapy for repetitive cutters, and this therapy was standardized on very difficult populations of mental illness, dialectical behavior therapy. So for those of you that already know of repetitive cutters, trying to find those in your community that practice a dialectical behavior therapy. We can't do it in the schools. Very complex therapy involving individual counseling, group counseling, skills training, but very effective with very difficult disorders. At the end, I've included some resources, but right now I'm taking a look at my clock, and it's looking like we're at about 5 minutes to 2, so I'm going to let my local host, Karen and Meredith, kind of take over now, or maybe we'll entertain some questions from folks.
Thank you so much, Rich. We do have a couple of questions, if you're willing. We have one that came in from Donna. Could you clarify when you call parents and when you don't?
Yes. Well, once again, I do want to caution everyone to talk about your local regulations. But here, as in Cleveland, as in New York, I mean, we are all mandated reporters. So if a child is observed with an open wound that has been self-inflicted, I really do think that you must follow the process, which is to reach out to the family and make the appropriate notifications. Many times kids will say, you see, there are similarities here between non-suicidal self-injury and suicidal behavior, both forms of self-harm, and there are two critical responses to kids that appear to be at risk for these behaviors. And one is they need to be supervised throughout the assessment process. So the nurse, as soon as the nurse or the aide becomes aware of these behaviors, you must start the supervision. I would never send the student to talk to the psychologist or whoever is going to do the assessment for suicide. In Los Angeles, nurses have been trained in that assessment, and I did give you a handout on assessing kids for suicide. But supervision is critical, and then making the appropriate notification. Sometimes, almost every student will say, please don't call home. And what I will do is I will show them the emergency card, and I will say, look, you got 5 names on the emergency card. If you don't want me to call your mom, who on the emergency card do you want me to call? I have to call someone. Now, you can make the call, and I'll sit here with you. I will make the call. You can sit here with me. It's the first time of empowering a student to make decisions for themselves in their own care. But let's be clear. If a student shows up and shows you a scar and says, "Oh yes, I did that when I was back in middle school," I would say that is not reportable. That it would be more important to use that and to use that connection that they have shared with you. To build a relationship in case the impulse comes back for them, and with kids this impulse can come back. But certainly if a student has an open wound, that is going to be a signal to follow the procedures and make the mandated notification.
Okay, great. Thank you. One more. What should we be doing for kids that return to school from hospitalization? How much information can we share with staff?
That's a great question. I think that what my experience has been with students that come out of treatment for 72 hours is that the parent, first of all, here in Los Angeles, kids are never hospitalized close to their home. That's probably the same by you. So the parent for a 72-hour hold has been generally traveling over the weekend or for all 72 hours, spent the time on the highways going to and from. So on the day the student returns to school, they can barely slow their car to 30 before they just kick the student out and say go back to class. Now the problem with this that we have had is when students go back to class and the teacher is unaware that they're returning from a hospitalization, generally all the students in the class know because they've been clicking on social media all weekend. This has created bullying for kids that come in from 72-hour hold when we know that is their most vulnerable time, the hours that follow a 72-hour hold. So I would sit down at the beginning of the year, establish policies and procedures that parents are to escort their student back to school on the day that they are to return to school. Now, some schools here have attempted to kind of side the process here by saying, if you do not have a letter that says you are safe to return to school, you cannot return to school after hospitalization. And that is illegal. When students show to be registered, they have to be registered. 90% of these students that are returning because they are harmed to themselves and not harmed to others, and they are much better served in school where they have the support of their support system at school than being home alone and isolated where the impulse would be easy to come back again. So having the parents escort, getting the signed releases, especially if medications are available or involved now, modifying the program as we would any IEP to create something that is workable and copable for the student, and a follow-up on the counseling services. Where are you going to receive some counseling here? If the student has an IEP, they do have some counseling possibilities at school, informal and formal counseling possibilities. Are you going to see follow-up by an agency in our community? Let's get a signed release of information so we can all talk to each other. And about releasing information, I say we really need to be talking more, not talking less. I know we're concerned about HIPAA and FERPA. We've created FERPAphobia. We're afraid to talk to each other. But if members of the crisis team in a confidential group come together and say, it's very important that these 3 teachers know this student is struggling with medications, and they give them an opportunity to adjust their program, connect with the student, and most importantly, monitor that student through the crisis.
Okay, thank you so much. We have reached the end of our hour. Rich, we want to thank you so much for a wealth of information on a very challenging topic. To our listeners, when the webinar ends, you will be receiving a survey questionnaire. You need to fill that out, and then that will automatically generate down the road the certificate that we have referred to. So please make sure you get that filled out. It should pop up right after the end of the webinar. Again, Rich, thank you. Meredith, thank you. And thank you to all of you who participated. Goodbye.
Go Cavs!
Yes.